topic is scapulothoracic arthroscopy. I'm not super experienced with this, but I have done some cases. And this is a short introduction or short historical overview of this topic. So 150 years ago, it was described by Bonnet, snapping scapula syndrome with a palpable audible crepitus, popping, grinding, and pain. Then it was done classification according to the severity of the symptoms. Codman recognized connection between irritation and scapular tilting. It was in 1970 described repetitive microtrauma, which may lead to osteophytes. And then we have those surgical steps, open surgical resection of the superomedial scapular angle, described by Milch. And then later on, arthrodebridement of the scapular bursa, and even more arthroresection of the superomedial scapular angle. This is, like Dr. Castagna said, is an uncommon condition, mainly with young active population, with overhead repetitive activities. In the physical exam, I think we are all familiar with this tenderness over the superomedial corner, or sometimes inferior pole of the scapula. This is really rare. Also, paraspinal muscles can be painful. There is a palpable crepitus, or sometimes also audible crepitus or snap with shoulder abduction and shrugging. Scapular winging can be seen, and evaluation of the posture is very important in my hands because we can see some asymmetry or some, we have to see what is the shape of the back. The etiology can be soft tissue, so bursitis, or even soft tissue masses. We can have some bone abnormalities, like erectile bone spur, or even osteochondroma. Also, abnormal scapular curvature is possible. And then we have a group of etiology, which I think that is really important and can be influenced very well with good physiotherapy, and it is in connection what just described Di Giacomo. So there can be a muscle asymmetry, weakness, atrophy. So I think that this, when the scapular control is not normal, this can be really important in this etiology for the scapulothoracic problems. So this is how we think that this pathomechanics of the bursitis works. We have a scapulothoracic bursitis because of the overuse or repetitive motion, sometimes because of the acute trauma. Of course, the anomalous anatomy helps with this. And then we got chronic irritation, inflammation, and bursal fibrosis. Sometimes it goes to the recalcitrant bursitis, and sometimes irritation of tissue cause the muscular microtears and chronic inflammation. As I already said, bony variations and abnormalities can even exaggerate the problem with the hooked superomedial corner or Luschka tubercle and so on. So we can do some measurements, and this was described mainly by the Millet group. So we can describe the costomedial angle. This is the angle you see here, alpha, between the scapular plane and the superior part over the scapular spine. We can measure the superior angle length and also anterior scapula offset. Of course, the imaging is very important because we have to rule out bony abnormalities, like here on the left with osteochondroma. The 3D CT scan is very important if we want to see what is the real shape of the scapula, and to distinguish possible cause of the, let's say, impingement or the contact between scapula and thoracic wall. And MRI sometimes will give us some clue about the bursitis or some soft tissue problems. When we send the patient to the imaging, it is important to notice that we need a picture of the whole scapula, otherwise the people who are doing this may not include all the scapula into the examination. So the management is primarily non-operative. So we try with several months of conservative therapy with rest, activity modification, non-steroidal drugs, injections, and what is, I think, very important is focused physical therapy. We have to do on the muscular strengthening of the periscapular muscles. We have to address any scapular dyskinesia, and we have to improve the posture of the patient. And success can be from 50 to 80%, which is quite good. For the operative treatment, indications is only in symptomatic patients which failed appropriate non-operative therapy. And sometimes we can help ourselves before with the injection on the supromedial angle. If pain subsides after this injection, this can be a sign that maybe operative treatment is helpful. So arthroscopic treatment gives us less morbidity and improved cosmesis comparative to the open treatment. We have to know the relevant anatomy of the back of the periscapular muscles. We have 3 layers: superficial, intermediate, and deep. Intermediate is in between the scapula and the vertebrae. We have to know the location of the bursa. So this scapulothoracic bursa can be involved in the snapping scapula syndrome. And we have to know what are the structures at the risk. So we have a spinal accessory nerve, dorsal scapular nerve, long thoracic nerve, and maybe also suprascapular nerve if we're going too laterally. And there is an artery, and we want to avoid the bleeding. So the safe zone is 3 centimeters medially to the medial scapular border. We have to remember this, and if you want, you can read this article, which depict the anatomic safe zones very well. Surgical technique is patient is in general anesthesia in prone position. We put the arm into full internal rotation. We medialize the shoulder. The safe zone is, as I said, 3 centimeters medial to the medial border. This is so-called chicken wing position. We do the portals on demand. What I think is very important is that the portals are not too close, because sometimes there is a long distance and it is difficult to triangulate, and instruments come into the contact with the scope. Trajectory of the instruments is more lateral than deep, and we can use the blunt instruments to develop the space. We can use a spinal needle for an orientation. We have to avoid excessive resection of the muscular fibers and fascia on the medial scapular border, because this is, as was already explained, the attachment point of the subscapularis and serratus anterior also. We have to use suction carefully, and preoperative planning is important. This is one of my cases, 22 years old boxer, which have pain on this left shoulder. This is a postoperative view, but CT scans are preoperatively, and this is the postoperative images, and with a resection of the superomedial angle of the scapula. So here we can see the first step, how we develop the space. Then we clean a little bit with a shaver, and also with electrocautery device, with a radio frequency device. we go slowly towards this superior medial angle of the scapula. We expose this, and we expose with a radiofrequency device. Then we start to bore. It is important to know that the scapula is very thin, and we are very quickly through the scapula, and we can change the portals to have another look from another point of view, and also we can do some better job in this way. So postoperative care is very simple. We try to do the physical therapy after the 1 week. What are the outcomes? This is a paper from the 2017, small group of patients. They described good pain relief, but residual palpable crepitus in 3 patients. Millie group published this study. I think this is the study with most patients involved, 60 patients, and even good follow-up with a minimum 2 years. They reported on some revision surgeries in 11%, significant improvement in the functional outcome and satisfaction rate, and the poorer outcomes are associated with age and longer duration of the symptoms. And this is a systematic review. The 203 shoulders included, 20% of complete resolution, about 70% of some clinical improvement, and 11% of poor outcome. If I come to the conclusion, improvement is with the surgical therapy is possible in 70 to 90%. If we treat this sooner, it's better. Residual symptoms is possible. And I think that it's important that we educate and discuss expectations before surgery. I think this is very important because there is a likelihood of persistent symptoms. Thank you so much.